like NIPPV in there, when should we be considering high flow with our COVID-19 patients? I mean, obviously there's those times that, you look at the patient, they need to be intubated, but there's also this discussion on just going straight to intubation, or actually should we be using these other devices with these patients?
Yeah, and I think that's an evolving story. If you would have asked me this 3 weeks ago, I think the consensus was that they were intubating all these patients early, right? And what they found is that the mortality was extremely high as 80% in some places. And so I don't think clinicians were okay with the death sentence that they were handing down people if they put them on ventilators, right? So if you knew that 80% were going to not make it, it made sense to look at other avenues. And what they found out is that this disease is unlike anything we've ever seen, and it required a treatment unlike anything we've ever done. And so now over the last 3 weeks, we've kind of found the answer that these patients are hypoxic and can be profoundly so, but their compliance for the most part is really good. So there's only a very small subset of them that have typical ARDS-looking lungs, or these heavy, wet lungs. And that's what Dr. Gadenoni out of Italy has called the H subtype. Now, the most of these people are his L subtype, which is this low-weight, hypoxic lung that can be easily treated with modalities other than mechanical ventilation. And so we've really seen the emergence of other technologies. Now, when we talk about aerosol-generating procedures, if you're a respiratory therapist, darn near everything that you do is an aerosol generating procedure. And we know that the most risk to the healthcare workers is in anything in manipulating the airway, right? So the most, or the majority of that, or the highest risk procedure would be endotracheal intubation, right? So in all the procedures that go along with that, or like putting in OG tubes or NG tubes, or supporting the airway through that procedure, like back valve masking and things where masks and aerosols are removed from the face or put back on the face. And you can just imagine that the air circulating around just from moving things in and around their airway. So because of that, they've really looked at other ways to support their oxygenation without having to do those more invasive procedures. And so there came the emergence of treatments like high flow and high velocity nasal oxygen.
Well, and also with our, concern of not having enough devices, right? If the patient's a candidate for it, then we're conserving some of the devices that they're worried we're going to be running out of.
I think originally they were saying high flow, high velocity nasal cannula does not work, so don't bother with it. Well, I think you had to take that with a grain of salt. They were really saying that these patients are going to go on to need intubation anyways. And really, if you use our old definition of who needed to be intubated, that was probably correct, right? And what would that be? Well, if you saw somebody with a SAT of 75, chances are you were going to intubate them. Well, that was because we'd never seen anything that could cause profound hypoxia like we have with COVID, right? We've never seen people literally walk in with a gray ashen appearance with a SAT of 50. It's just not something that we've typically seen. And yeah, in the days before COVID, you would put a tube in that person almost immediately. And we found that, hey, that's not the right way to go, that you can support these folks with treatments like Vapotherm very well, keep their SATs up and keep them supported while they clear their disease.
And I think that that's the main thing. We're needing to support these patients because this particular disease, it's a lingering, right? Even where I'm at right now, we're looking at the numbers and it's like the cases keep increasing and the recovery cases are growing so small. And so it's just like, a couple here, a couple here. So to be considered recovered, it's taking so long.
Well, yeah. And we're hospital people, right? So think about the recovery of a patient that does come off the vent. These patients are averaging 2 to 3 weeks on the vent at best, right? If they're able to wean from the vent, it's going to take them, really the duration of this COVID pandemic in the US is about 3 to 4 weeks now, right? So people that were intubated in the early stages in New York are like just coming off the vent now, which is kind of crazy. And therein lies the issues with resources, right? It's not that, they get this huge surge and they need all these vents all at once. It's that these patients just don't come off them. And so if you have a technology like Vapotherm that can support patients and maybe keep them off for a couple hours or maybe a couple days, or think about the back end where they can wean from the vent and go to high flow nasal cannula, then maybe you can shorten their course on the back end, making some of those resources available to new patients that are going to require them.
Yeah, I think this is the first time in the United States that we've ever been like a resource limited country. There's other countries that are used to doing these types of things, right? So it's kind of getting a taste of what some of the non-first world countries, right, have.
Yeah, we were very high on prepping for disaster and being prepared after 9/11. But geez, it's been almost 20 years and I think people have forgotten, right? And so I came from a military background where we trained on this and we did have limited resources. We were taking care of patients in austere environments where we got used to doing things like this. And so fortunately, a lot of my colleagues have spread around the country and are bringing their expertise to this. And so I think in what you've probably seen relative to like Italy is that the United States has really jumped on this, has found new cures, new ways to treat this, and have really done a good job in mitigating it. I mean, we saw, a heck of a disaster in New York City, but we've really stemmed the spread and, having better successes than that 50 to 80% mortality rate that we were seeing initially.
So with the high flow cannula, is there any tips or tricks in reducing transmission risk for that healthcare provider?
Yeah, so we actually looked at this. And so our science and innovation team did a wonderful study that was published in Chest I guess it was last week now, where they looked at the transmissibility of viral particle droplets and aerosols from our high flow cannula, our high velocity cannula. And what they found is that if you do the things that you should do to any patient that you suspect of having COVID, which the number one thing to mitigate their spread of disease is to put a surgical mask over their face. So if you do that and you apply our cannula under it, it will significantly reduce the transmission while using the device. So much so that it is modestly more risky than using a regular nasal cannula at 6 liters. Many of these patients really should have a surgical face mask in place and the cannula applied underneath.
That's a good tip for those that might be using this or to be able to prevent them from getting it. Because I know I've seen respiratory therapists are getting COVID and I've seen some sadness on like different social media boards where respiratory therapists have even passed from it. So protecting ourselves is number one, because if we aren't protected, then we can't care for the people.
Yeah. And that's the way that I operate too. My people come first. Their safety comes first. I'm never going to question somebody for wearing a fancy mask or taking more time to don and doff their PPE. But honestly, if you want to mitigate more so than wearing your PPE, if you want to mitigate your risk from this, all these patients should have masks on. And that should really happen when they, hopefully prior to entering the facility, right? So do that. And then what I'm telling you is don't remove that mask. Just put our cannula under it and you'll significantly reduce the viral spread. That mask actually acts almost like a catcher's mitt. So for any droplets are largely going to be caught up in that. And then any aerosols are going to lose all their velocity, right? So they're going to hit that catcher's mitt and basically drop in the vicinity of the mask, right? So it's not like a cough that is going to spread things. What are they saying? I know 26 feet or something like that, right? So all that velocity of a cough or a sneeze is all going to be caught in that mask and drop just in the vicinity of it. So in and around the patient's face. Now, that of course that's the working area of a respiratory therapist. So I'm not saying don't wear your PPE. I'm not saying don't be careful if you're going to be near a patient, but it's going to mitigate that risk.
Well, I think it's just one further step, right? We should be protecting ourselves with our PPE, but how often previous to this situation, how often would you throw a mask on a patient other than their nebulizer? Probably not. So this is something that maybe we need to be using more masks, and we are using masks as, people going out in public, they're wearing masks to protect themselves. So having those patients with those masks in the hospital, it can help within that environment so that we have less cross-contamination, less risk, because, our healthcare providers are on the front lines and they are doing these things. So I guess every little bit helps. So putting a mask on the patient, go for it.
Yeah. Think about this. We've been using nasal cannulas in different aerosol generating procedures to care for infectious patients forever, right? But when did you ever think about this, right? Like talk about like the swine flu that killed hundreds of thousands of people in the US, right? We never even thought to put a mask on them if we're going to put them on a cannula, or different ways to mitigate the risk to us if they had to be on a non-rebreather, if they had to be on a veni mask or whatever it was, right? Or let's talk about giving aerosol treatments. We never thought about different ways to mitigate our risk. And that's probably why we had disease like that spread. And so this experience with COVID is certainly going to improve our understanding and, kind of across the board. So how we protect ourselves and how we mitigate risk to other patients in the facility or, where we care for them in our hospitals. We're gaining tons and tons of knowledge.
So I know that with high flow cannula, or specifically with Vapotherm, you look at it more as a de-escalation device. Where have we been setting the starting flows for these patients, or how do we decide what is the starting flow for the patient that we're dealing with?
All right, so I'm going to rewind a couple weeks. And basically the recommendations were, hey, we don't know how much aerosol you're generating. So if you're going to use a high flow or high velocity device, it might make sense to keep their flows limited. Use what you would normally use less than that. And there was no good recommendation, but it was like, hey, it seems reasonable to us. And with the studies that we've done, that is kind of all hooey. And really what you should be doing is treating the disease to the extent that you need to with the flow and with the FiO2 provided by the device. And so if you have a very hypoxic patient, I would suggest starting them on full treatment. Now, the other thing that you would need to know is that by putting a surgical mask over their cannula, you do lose a little bit of the flush effect if you're talking about CO2. Now, that's important if you have a patient with comorbidity, right? So if you have somebody who is mixed hypoxic and hypercarbic failure, like a COPD with COVID, you need to worry about how efficiently you're going to flush that CO2. And so those patients, I would treat them up to 40 liters, which is the max on our device, right? So, and we studied that. So when Scott Leonard and George Duncan and Ron DeBellis did this study, they looked at worst case scenario. And so they had the patients with high respiratory rates on high flow rates and non-negative pressure rooms, and they wanted to see how far this stuff flew. So what I would tell you is 40 liters, FiO2 per the patient's needs, and go from there. So if you find that they don't quite need that flow, I would back it off.
No, that's good to know. I think one of the amazing things during this is how much research is being done so quickly.
Well, I mean, that's how medicine operates. And in particular, that's the American way, right? So if we have a problem, we're going to solve it. And when it comes to our people, that's our most precious commodity. And so we need to save lives. We need answers now. I mean, you can look at the FDA. They're expediting review on new drugs, new containment units, whatever it is, right? They're doing everything they can to get the, let's talk about helmet CPAP, right? That's something that's not widely available in the US, but certainly those things are being looked at very closely and expedited to market by the FDA.
Yeah, because I've seen it in Spain and Europe, but I've never seen it in the States. So it's definitely interesting to see how one significant event is triggering so much, and that we are just coming together to say, you know what, let's make it happen. This is a worldwide problem. And, I think we're doing a pretty good job on trying to mitigate it and take control and get our lives back.
Yeah. I mean, Americans are generous and loving. And, our community, we're the most philanthropic country in the world, right? So we are learning things now that is going to impact the health of the world for generations, right? So medicine as we know it is going to change forever and likely for the better. And I equate that to our experiences in the military, right? I'm an ex-Air Force doctor, and our experiences in Iraq and Afghanistan have really changed the way that we take care of trauma, or we'll say interesting exotic infections or whatever it is, right? We've learned a lot, and that has, translated directly over into how we care for patients in the US. So I'm excited to see how we're going to move forward with this. I'm excited how we're going to take care of respiratory patients differently. Just imagine the next time you take care of somebody with flu, right? You would have never thought to put their high flow or high velocity nasal cannula under a surgical mask. It's just the flu. Well, people die of flu. And, we don't want our therapists, we don't want our nurses and our physicians getting sick from this stuff. So I think a lot of good is going to come out of this.
No, I totally agree. And I thank you for your time today and talking about this. And, it's timely and I want to get some information out there because I know that we're facing things that we've never faced before. And sometimes, you don't think of something so simple of just putting a mask on the patient's face on top of their cannula to protect yourself.
Yeah. So, and before we finish up, I want to just share with you that, my mother's a respiratory therapist. She actually just retired after, 30 some odd years. And so a lot of my foundation in medicine has been taught by her and her colleagues in respiratory therapy. So I owe you guys a lot as a community. And certainly through all this, I support you. And if any of your colleagues have any questions, they can certainly reach out to me and you can share my contact if you wish. But the biggest thing I have is put yourself and your colleagues first, right? Stay safe, do everything it takes to protect yourselves. And be well.
All right. If you guys need any information, just email me at theventroom@icloud.com and I can get you guys connected. You guys have a safe travels and working and just protect yourselves out there.